Hello everyone, this is Suprava. Welcome back to another session with me. In today's session, we will be discussing about dysplasia of hip. Dysplasia of hip means there is presence of abnormal cells in the tissues or in that particular part of the body, right? So this dysplasia of hip was previously known as congenital dysplasia of hip, and now it has changed to dysplasia of hip. So that means it is not only congenital, but it also can be acquired during the infancy or in the childhood. This is also known as developmental dysplasia of hip, and this comprises a spectrum of disorders. So there might be acetabular dysplasia, or there can be a shallow or underdeveloped acetabulum, and this might be associated with neuromuscular conditions or other genetic disorders. Next, moving on to the etiologies. So in etiologies, the first factor is genetic factors. Genetic factors plays a major role in development of dysplasia of hip. The next thing is hormonal changes. So hormonal changes in late pregnancy can aggravate the ligamentous laxity in the infant. And also if there is intrauterine malposition, especially in case of breech position along with extended legs, that would favor dislocation. Next, moving on to the degrees of dysplasia of hip. So the first one is dysplasia. Now this condition is found as shallow acetabulum where there will be upward slant of acetabular roof. The next one is subluxation. So in subluxation, what happens? The acetabular surface of the femoral head will be in contact with shallow dysplastic acetabular surface, but the head would slide little bit lateral and superiorly. And the next one is dislocation. So in dislocation, what happens? The articular cartilage of completely dislocated femoral head does not contact with the acetabular articular cartilage. So this was all about the degrees of dysplasia of hip. Now moving on to the clinical features of dysplasia of hip. So here the main motto is to diagnose every child at birth so that the prognosis can be very good. So that is the reason we have to examine each and every child at birth for any sort of dislocation, if there is any presence of dislocation or if there is any signs of instability. And in case if there is a family history of congenital instability or if there is breech presentation and if there is any signs of other congenital anomalies, then you have to examine the child very thoroughly. The clinical features can be different for each child. However, there are certain clinical features which are common for dysplasia of hip. So the leg may appear shorter on the side of the dislocated hip, and also this leg may turn outward. And the folds in the skin of the thigh or in the buttocks would appear uneven. And apart from these things, the space between the two legs may appear wider than normal. Next, moving on to the diagnosis. So how we can diagnose this condition? As I told you that each child should be examined at birth properly so that we can find out if there is any sort of signs of dislocation or any signs of instability. So there are several tests which can be performed for neonates and infants to find out if there is any instability. So firstly, we have Barlow's test. So what Barlow's test does, it dislocates the dislocatable hip by adduction and depression of the flexed femur. Next, we have Ortolani's test. So Ortolani's test reduces a dislocated hip by elevation and abduction of the flexed femur. And then we have Galliz's test. So in this we can see an apparent limb length discrepancy due to a unilateral dislocated hip with a hip and knee flexed at 90 degrees. And the femur would appear shorter on the dislocated side. And you have to direct the force posteriorly. So if the hip is dislocatable, that means if the hip can be popped out of the socket, then the test is considered as positive. And then after this, the Ortolani maneuver can be performed to confirm the findings. Next, we would see how Ortolani's test is performed. So in Ortolani's test, the baby's thighs are held with the thumb and the fingers would be resting on the greater trochanter. And after this, the hips are flexed to 90 degrees and gently abducted. So usually there would be smooth abduction to 90 degrees, but if there is, if it stops halfway, that indicates that there is some problem. Apart from these things, so we can also perform X-ray, CT scan or MRI, or we can also do ultrasound. Next, we would see that if we miss diagnosing it at birth, then if we are diagnosing it after 6 months of their life, then what are the manifestations that we would see, or how we would diagnose it? So firstly, there would be limited abduction of the affected hip, and there would be limb length discrepancy. And if it is unilateral, then in that case the child will limp, and if it is bilateral, in that case there would be waddling gait. Next, moving on to the treatment. So in treatment, we can see abduction, splinting or bracing. And then there will be closed reduction and spica casting. And then if these does not work, then there can be surgical intervention. So for that, there will be open reduction with spica casting or open reduction with femoral osteotomy. Next, moving on to the complications of dysplasia of hip. So firstly, there can be avascular necrosis. Also, there can be loss of range of motion of the affected hip. Leg length discrepancy will be there, and also there will be early arthritis. And there can be femoral nerve palsy or recurrent dislocation or unstable hip. So let us conclude here. So that was all about dysplasia of hip. I hope you have got a better insight about the topic. Thank you.